Good afternoon, everyone, and welcome to our webinar on managing acid-base balance disorders with Dr. Hasan Arif. So before we start, I'd like to say a few introductory remarks about Yetenaweg. So Yetenaweg is registered in Pennsylvania, USA as a non-profit organization, and it's run by volunteer members. We currently have more than 70 active volunteer members from 5 different countries globally and counting more. As you can see from the image on the right-hand corner, that's a picture of our volunteers at a recent get-together. So our projects and engagements can be seen in 4 aspects. The first is health promotion, which is done via discussion in the article regarding the health of the general public and health policy and its implementation. Our second project is the community engagement, which is done through blood drive, inclusivity, equity projects, fundraising, and campaigns. Our third engagement is the mentorship and skill sharing, which provides direct mentorship, soft skill, career and professional development webinars to healthcare professionals. And the last, medical education, which under it has the continued medical education, research and quality improvement projects. So Yetenaweg is more than a digital platform. It provides a platform where the volunteers can come together and contribute in a meaningful manner to health and more. So this is a slide showing a picture of our volunteers during activities, including voluntary screening, donation campaigns, and inclusivity training projects as well. So our other activities, the Yetena Groha Health Article Writing Competition, which is done in collaboration with IMSA. So the first round of Health Article Writing Competition in collaboration with IMSA and Roha Health Foundation has been announced on September 2. Roha Medical Campus through Roha Health Foundation will award travel grants to the winners of the whereas Yetena will award pulse oximeter and Leitman stethoscopes. And the top 5 winners will also get internship opportunities at various health and other institutions as well. So if you've been following our social medias recently, these are successive posts announcing the annual article writing competition. So if you are a medical student in Ethiopia, you can participate in this article writing competition. So this is a slide showcasing the 2021 article writing winner and the prizes that were prepared for the 2022 winners. And these are the 2020 winners that got the opportunity to travel abroad to Rwanda to the University of Global Health meeting. Our other engagement is done in collaboration with Roha Research Fellowship, in collaboration with the Kurambasa Specialized Hospital and St. Paul Hospital Medical College. So the first wing started on March 14, 2023. So Kurambasa Specialized Hospital, 3 departments, mainly oncology, radiology, and internal medicine were involved. Research grants were awarded for the top 4 winners, mentorship for the subsequent year. And the second is St. Paul Hospital Medical College, was prepared for medical students. Research grant award was granted for 4 winners. The winners have already been announced, and the second phase has already started and is well underway. So this is the winners from Kurambasa Specialized Hospital, 2 residents from internal medicine, another resident from radiology, and another from oncology. And these are the winners from St. Paul Hospital Medical College. So when we come to our CME sessions, they're freely accessible. And for the CME sessions, Yetenaweg collaborates with the Ethiopian Medical Association, with the Ethiopian Society of Cardiac Professionals, and the Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. We invite renowned local and international speakers. We've had 22 CME webinars held for the year 2024 so far. And our average webinar attendee spans from 150 to 200 healthcare professionals. And for 2024 alone, we've planned to have approximately 30 webinars, each focusing on emergency surgical and medical case, ENT, pediatrics, OBGYN, and more. So you can access our previous CME sessions by going to our Yetenaweg YouTube channel. And you can get updates about our upcoming CME sessions by joining Yetenaweg's Telegram channel for healthcare professionals, or you can follow our social media posts. The links will be posted in the chat box shortly. In order to get the best experience in the webinar, you can send your questions on the Q&A or on the chat box. And at the end of the webinar, your questions will be addressed by the guest speaker accordingly. And in order to get CU certificates, you must fulfill the following criteria. The first is attend the whole session virtually. The minutes attended will be checked by the Zoom attendee reports. You have to fill the Google form for personal details and attendance, and you have to score 50% or more on the post-CME quiz. So you will be able to see your result right away, but the certificate will take at least 2 weeks to be delivered to your email. So In that time, we ask that you wait patiently. So having said that, thank you. I would like to introduce our guest speaker today. Our guest speaker today is Dr. Hasan Arif. He's a clinical associate professor in the Division of Nephrology at Thomas Jefferson University Hospital. He completed his medical education from Dow Medical College in Karachi, Pakistan, and completed his residency and fellowship from Drexel University. And he's been in academia for the past 10 years. So without further ado, I'd like to welcome Dr. Hasan. Dr. Hasan, please proceed.
Good morning, everyone. It's a pleasure to be here. Thank you for setting up that CME seminar. We've done two already, one with potassium, one with sodium. This one's on acid base. With that, I will turn off my camera and I will start sharing my screen. Just want to verify, can everybody see my screen, please?
Yes, we can see your screen, Doctor.
Perfect, thank you. Okay, with that being said, we'll start with management of acid-base disorders today. No disclosures, as always. Everybody knows that there are different types of acid-base issues. One is respiratory, um, and with respiratory, you have your alkalosis, your acidosis, acute, chronic, and in your metabolic panel, you have your alkalosis and your acidosis, which is GAP and non-GAP. The problem comes is that even though every situation kind of labels that treatment of these disorders need the underlying primary cause to be treated, patients don't come with either a suggestion of what they might have, nor do they come with a label on their forehead saying GAP metabolic acidosis, please treat me. So part of the problem is that we'll tackle today is we'll approach cases, which is what we see, which is the clinical aspect of everything. And then based off of that, we will interpret the data that we see so that everybody who's attending this seminar can at least understand how we interpret the ABGs, the arterial blood gases, as well as the chemistry for us to get to the answer that we need to get to. And based on our results, we will then start with the treatment summarization as to how we approach a patient and how we get their acid-base status corrected. So first and foremost, we will go through some rules when it comes to acid-base interpretation. The first rule is that your pH determines your primary disorder, meaning to say whatever your pH shows up as, that will be your primary disorder. You may have more, but the primary disorder is identified with your pH. You only need 5 numbers to work up an acid-base question. From the arterial blood gas, you get your pH and you get your partial carbon dioxide pressure. And these two will be helping identify what kind of acid-base issue there is. And with the blood chemistry, you will get your sodium, your chloride, and your bicarbonate, and that will identify whether there is a gap or not. At any given time, you can have a maximum of 3 disorders and no more than that. So a combination of 2 acid-base issues, metabolic issues, and 1 respiratory issue at any given time. The reason being that you cannot have respiratory acidosis and alkalosis in the same patient at the same time, as you cannot breathe fast and slow at the same time. So you can have a combination of 2 metabolic issues in the patient and 1 respiratory issue in the patient at any given time, pushing it maximum. Otherwise, you'll probably be dealing with just 1 issue at any given time. And at the end of it, the last rule is that when your body is trying to adapt or help you compensate for whatever issue you have, you will never get back to normal. The body does enough to keep you where you are so that you can survive while the body or your medical team deals with the issue at hand. So these are normal values. Your pH is at 7.4, which is normal. Your PCO2 is at 40, which is normal. Partial oxygen levels are here. Bicarb, this is a calculated value, so don't go by this. This is a measured value. We will always use this instead of this. And this is your oxygen saturation. Sodium's given up here, which is normally at 140. Chloride is at 105. And again, bicarb hovers between 24, 25. So these 5 are the numbers that we're going to be using in any and every medical questionnaire that we're going to be solving today. This is a schema or a diagram of acid-base disturbances. First and foremost, you need your arterial blood gas, and the pH will be available there. From that, you will either see an acidemia or an alkalemia in the patient. Based on acidemia, the first thing we look at is the arterial partial pressure of carbon dioxide. Sorry. And the reason for looking at the PCO2 first is because the respiratory component is the first to compensate or adapt. And if there is a problem in your acidemia levels, meaning you have acid in your blood, the lungs should be trying to help by blowing off volatile acid. What is volatile acid? Carbonic acid, okay, which is basically dissolved in the blood. So if the partial pressure of carbon dioxide is greater than 40 millimeters of mercury, the lungs are the reason why your pH is less than 7.4, because you're holding on to the acid that you should be blowing off. And hence it's called respiratory acidosis. Okay, so we kind of look at lung issues. If it is less than 40, it means that the lungs are blowing off the acid that they normally, and the normal values are 40, and therefore the lungs are trying to help, and we start looking for a metabolic issue. Similarly, the opposite is true for alkalemias, where for whatever reason you have more alkalemia in your blood, which is greater than 7.4. And in that scenario, the lungs should be holding on to acid to neutralize the alkali in the blood. So your partial pressure of carbon dioxide should be greater than 40, which means the lungs are trying to help. And then we start looking for metabolic issues for why the patient has alkalemia. If the value of the partial pressure of carbon dioxide is less than 40, we start looking at respiratory alkalosis. Why? Because for whatever reason, your blood is alkalemic and your lungs are blowing off the acid that they should normally be holding off to. And hence, there is a problem in the lungs as to them creating an alkalemic environment. So that's how we will approach each and every question, by looking at the arterial pH and then looking at the the partial pressure of carbon dioxide. And based off of the interpretation of the two, we will either label the scenario as respiratory or metabolic. And the simple question that one has to ask themselves is, are the lungs trying to help or the lungs creating a problem? And that will be our question for each and every question that we're going to be solving. So for metabolic disorders, first and foremost, for every metabolic questionnaire that we're going to be solving, we will calculate a gap. We will take all the positives, add up all the negatives, and subtract all the negatives from the positive, and we will end up with a gap. These gaps are arbitrary. They are not real. Your body is neutral. This positive 12 gap that you're seeing is ideally neutralized by negative 12 charge on your albumin. Okay, so we are neutral individuals. We do not go around sparking or electrocuting each other because of this positive 12 that we're seeing. This is an arbitrary number that you're seeing. This does not exist at all. If somebody has a high anion gap, meaning that this gap is greater than 12, is only when we're going to be calculating a delta, and we'll get to this as to how it is calculated. If the gap is less than 12, we consider it a normal gap, and we try to figure out if the issue is renal or gut, as in negative, and we'll do that, and no delta is required for that. Okay, now how do you end up with a high anion gap? If you look at the mathematics of the 5 numbers that we have isolated, the 3 were sodium, chloride, and bicarb. Sodium was at 140, chloride at 105, and bicarb at 25. And when you did the math, you ended up with a gap of 10. So this is your normal gap. This is where normal people live. With a high anion gap, what ends up happening is that there is additional addition of acid. And because of that addition of acid, the bicarb that you have in your blood is neutralizing the acid, which means it's being consumed. It's behaving like an hydrogen acceptor. And hence, when you do the math over here, you're seeing that there is a high anion gap. There's a better way of visualizing this. And hence, even in this scenario, they are mathematically evident by an increased gap. There's no gap that actually exists. We are still neutral. The body is able to keep us neutralized throughout this scenario. So it's not like we are electrically active or electrically charged either positively or negatively. Excuse me. So if you look at it mathematically or in a diagram, this is your sodium at 140, this is your chloride at 105, this is the bicarb at 25, and this little gap of our anion gap that we're seeing is 10 to 12 is actually neutralized by the albumin, which is sitting at negative 10 to 12. So this negative 10 to 12 neutralizes the 10 to 12 that you're seeing because of this mathematical equation. In a high anion gap situation, you have your sodium at 140, you have your chloride at 105, you have your bicarb at 15. Again, it is what is neutralizing or buffering the acid that was added to the body. Okay, this could be any kind of acid. And hence, mathematically, what we're seeing is 140 and 105 plus 115. So it looks like there's a high anion gap. Again, body is electrically neutral. Everything is neutralizing itself. So we are still electrically neutral. If you have a normal gap, you kind of have to figure out whether the kidney is the culprit or the gut is the culprit. And there are very few scenarios of a normal gap metabolic acidosis. If the gut is responsible, diarrhea, ileal loops, all these situations can be causing loss of bicarb from the body. If it's a renal situation, then renal tubular acidosis or medications like carbonic anhydrase could be responsible for the cause in itself. And in order to figure out whether it's the gut or the kidney, we perform what is called a urine anion gap. But first, we'll look at how this normal gap metabolic acidosis occurs and how we maintain our neutrality. So again, sodium at 140, sorry, chloride at 105, bicarb at 25, and here's your normal anion gap. So this is what we normally calculate. Again, this is what is neutralized by albumin because albumin is at a charge of negative 10 to 12. You have 4 grams of albumin. Each gram carries about almost on average negative 2.5 charge. So 4 times 2.5 is 10. So that's your negative charge right here. And that's what's neutralizing the entire body and everything is neutral. Now, in a non-gap metabolic acidosis, what is occurring is you have your sodium at 140, your chloride, which should be at 105, has gone up to 115 for whatever disorder it is. Your bicarb has dropped because you were either losing bicarb or through some other process. But the mathematical equation doesn't change because when you take 140 and you subtract 115 and 15, which is a total of 130, you still end up with a gap of 10 to 12. Does that make sense? So this is more of a mathematical variance that one is seeing. And the reason for showing you this is because this kind of sticks in your mind as opposed to verbiage, which sometimes we can remember and sometimes we can forget. So all humans are visually are visual creatures, and visuality and cartoons make more sense to us. So this hopefully will stick in your mind to differentiate between gaps and non-gaps. Now, this is for delta delta only. Okay, this helps us figure out whether there is an underlying disorder or not. Okay, so for a particular patient, okay, we've done all the mathematical equation. You're seeing a patient with a pH that is, shall we say, 7.3. You calculated the gap, it's sitting at 20, sorry. And the bicarbonate of the patient is sitting at 14. This is available from your patient's ABG and your patient's chemistry. Okay, this line that I've drawn is kind of understanding or creating a balance that when you are at 24, your gap is at around 12. And the reason why I've given this is that some labs will say 10 is normal, some labs will say 12 is normal. Go by what your lab says. So this is your gap. This is your bicarb. For this particular scenario, we've calculated the gap to be 20. Agreed? 20 or 22. Let's just say 22. Now, over here, in order to get from 12 to 22, the number of molecules of acid that need to be added are around 10. Similarly, in order for this to drop down to 14, which is where it is given in the question, another 10 molecules of bicarb have to be consumed to neutralize this 10 molecules of acid. Hence, this drop is explained by this rise, and hence we can say that this is compensated or the delta delta does not exist. Now, what if the bicarb of the patient was sitting at 10? It means you have consumed more bicarb than is the number of acid molecules added, which means you have consumed more. So that means you have an underlying disorder. And whenever you have a loss of bicarb, you will call it an additional acidemia. Again, don't get worried about it. We'll be doing a ton of questions and it will make more sense as we move forward with the questionnaires. What if your bicarb was sitting at 20? It means you've held on to extra bicarb molecules instead of consuming them. So you will call this a metabolic alkalosis. And again, we'll do the questions and this entire scenario will make more sense to everybody. Okay. You can do it mathematically as well. You can take the delta gap, which is this difference, and you can add the bicarbonate, which is this over here. And if your answer comes out to 24 or 25, no underlying disorder exists. If the total is greater than 24, there is added alkalosis. If the total is less than 24, you have added acidosis. Okay. So if you want to do the math, 14 plus, what is the, that's the bicarb, and the delta gap was between these two is 10. So 10 plus 14 gives you 24. So no underlying disorder. If you take bicarb at 10, 10 plus 10, you're coming out to 20. So you have added acidosis. If you take 20 and you add it to 14, then you're sitting on, sorry, 10. 20 plus 10 is 30. You have added alkalosis. So albumin and its effect on the gap, we only calculated in the setting of metabolic acidosis. Like I said, each gram of albumin gives you almost negative 2.5. So when you see this positive gap, or what we call a normal gap, this positive charge does not exist. This 4 grams of albumin basically neutralizes this, and we will be adjusting the questions as the calculations occur for every gram of albumin, okay? So if you have less than 4 grams, so for example, your patient sitting at 3 grams, you will add 2.5 to the gap because that 2.5 of gap was not adjusted for. This is a cheat sheet, and this cheat sheet will be available to you guys. I will be sending the final presentation, and you guys can receive it from the webinar as well. So this will be available to you guys. These are just all the formulas that we use for adjustment. This is a schema of how we use them. Again, you are not being quizzed on your mental ability or acuity. You can look up these formulas. All we need to do is when we're taking care of the patient that we get to the right answer, right? So your ability to take care of a patient should not depend on your ability to memorize formulas. It should be based on your ability to apply the formula, okay? So these will be available, and we will utilize these to solve the questions as we move forward as well. So first and foremost, we'll start with single disorders. Let's start with the case. So here's a 44-year-old patient who's severely dehydrated, admitted with 2-day history of acute severe diarrhea. The sodium is at 134, potassium is at 2.9, chloride at 108, bicarb at 16, BUN at 31, creatinine at 1.5. ABG is showing a pH of 7.33, PCO2 of 33, and this is the calculated bicarb, and this is the oxygen levels, okay? So what is the acid-base disorder? We will be solving this right here, right now. I have the solution on the other slides as well, but let's start with this number is showing you what? Acidemia, less than 7.4. So this is an acidemic process happening in this patient. Okay, that's number one. Why? pH determines primary disorder. Now, since you have acidemia, since you have acidemia, what should the lungs be doing? Should they be holding on to carbon dioxide or blowing it off? And over here, you see them blowing off carbon dioxide. And since you're seeing them blowing off carbon dioxide, the lungs are trying to help. So this is going to be a metabolic issue. And the next step is, since we've called it a metabolic issue, we will calculate what is called a gap. And the gap over here is 134 minus 108 plus 16. That gives you around 124. So the gap is equal to 10. So this is what you're going to call a non-gap metabolic acidosis. Would you like me to repeat? Let me just look in the chat. Yes. Okay, good. No, and to tell you the truth, this is going to be repeated every time in all the questions. So this is not the first time or the only time we'll be doing a question like this. So again, first and foremost, first thing you look at is the pH. The pH in this patient is 7.33, which means there is acidemia. Why? Because we have said that anything less than 7.4 is acidemia or acidosis. So this patient is sitting on an acidemia. So the primary disorder is an acidosis. Number two, we are looking at the PCO2. PCO2 normally in patients is at 40. Are the lungs trying to help by blowing off acid, or are they holding on to acid? So by the fact that the lungs are blowing off carbon dioxide, i.e. volatile acid, the lungs are trying to help. So this turns into a metabolic issue. And since we've labeled it now as a metabolic issue, we will call it a metabolic acidosis. The question becomes, what kind of metabolic acidosis? And in order to answer that question, we have to calculate what is called a gap. And in the calculation of a gap, we take three numbers, which is the sodium, the chloride, and the bicarb. We take all the negatives to one end, which comes out to 124. We take all the positives in one side. And when we subtract 134 from 124, we end up with 10. Since 10 is a normal gap, we call this a normal gap metabolic acidosis. This helps you identify the fact that this patient is sitting on a normal gap metabolic acidosis, which means all the other causes of metabolic acidosis where a gap exists are automatically ruled out in this patient. So you're not going to be thinking of DKA. You're not going to be thinking of methanol toxicity, ethylene glycol toxicity, lactic acidosis. Why? Because they're all high gap. So all this tells you is that this patient has a non-gap metabolic acidosis. Okay. And I'll show you the mathematics over here. So working for a patient for 7.33 with a PCO2 of 33. First, we said acidemia, then we said metabolic. Then we said we have to calculate an anion gap. And in order to calculate the anion gap, we took all the positives and the negatives. And here's the math on it. And you ended up with a gap of 10. So this is a normal gap. Now, since this is a normal gap, we kind of have to figure out what the lungs are doing. Is this PCO2 appropriate for this pH? Since this is metabolic, we will calculate what is called Winter's. Winter's formula is straightforward. It is a complicated formula. You are, again, not going to be quizzed for your mental acuity in learning formulas. Okay? Use your calculators, use your formulas, use your smartphones. Okay, so for compensation or adaptation, we're going to use the Winter's formula. This is what the Winter's formula looks like. All you need to do is use this bicarb and put it in here. Okay, and the answer is, after you do all this mathematical calculation, your PCO2 should be 32 plus minus 2, which means a range of 30 to 34. And the PCO2 is sitting at 33. So this is appropriate. This is what your body is trying to do, to blow off carbon dioxide so you survive, so you don't die out. Or your patient survives, sorry. Okay, now, since this was a non-gap, we're going to look at what the urine is trying to do, because that's the pathway that we follow. These numbers can actually be looked at stool as well. But again, collection of stool is messy. And collection of urine is easier, and collection and measurement of electrolytes in urine is much easier than it is in stool. not to say you cannot do it. So in any patient with a non-gap metabolic acidosis, the next step is a urine anion gap. And a urine anion gap is exactly what it looks like or sounds like. You take all the positives and you take all the negatives. Sorry, where is an eraser? Pen. Here we go. So you took all the positives, which is the urine sodium and the urine potassium. You added them up and then you subtracted what is negative in the urine. These are abundant. It's not to say that these are the only ones, but these are the most abundant ones. So you ended up with, again, a negative 20 because of the math. The urine is not electrically charged. The urine is neutral as well. Just like your body is neutral, your urine is neutral as well. It's just a matter of what you're using to measure. So there's something that is being unmeasured in the urine, which is why you ended up with minus 20, okay? And I'll show this to you in a diagrammatic manner as to how we ended up with a minus with the urine being neutral as well. So here's the diagram. This is what we measured based on the question. Sodium of 20, potassium of 10, chloride of 50. Something's missing up here, okay? Now, in diarrhea, okay, just listen for a second. In the case of diarrhea, your body or your colon, your patient's colon is losing bicarb because of the quick flow of stool in the colon itself, which means bicarb loss automatically means addition of hydrogen. So when hydrogen is added to the blood and your kidney is seeing it, the kidney will ramp up its ability to get rid of hydrogen from the blood. In order for hydrogen to be trapped in the urine, the best thing the urine can do is create something that can accept hydrogen. And the kidney is very well equipped to generate something called ammonia. Ammonia can accept hydrogen. And when ammonia accepts hydrogen, it behaves like a positive ion. So that gap that you were seeing in the urine is unmeasured ammonia. So the calculation shows that there is a negative charge. However, through nature, through adaptation, through evolution, the kidney is able to generate ammonia, which behaves like a hydrogen acceptor. And hence, the mathematical equation, which should be showing you a gap of 20, is actually filled by ammonia in itself. Why do we not measure ammonia? The reason being, ammonia is very volatile. In experimentation, in experimental models, in lab studies, you can measure ammonia. However, the urine then has to be collected under a film of oil. It has to be kept at a certain temperature, certain probes have to be used. So it's a very cumbersome process. So in order to make life easy, and in order for you not to be waiting 3 days for a lab result to come back, the easier way to do is to check a urine anion gap. And when a urine anion gap exists like this, you're saying, oh, the patient is generating ammonia. So if a urine anion gap is negative, it's the gut. Okay? That's the only time you're going to have a negative urine anion gap. If the urine anion gap is positive, it's a kidney issue. Something's going wrong in the kidney. And again, we'll be doing examples where there will be positive urine anion gap. So again, mathematically speaking, this minus 20 does not exist. This minus 20 is neutralized or is already being neutralized by this positive ammonium that has accepted hydrogen. Okay, so the kidney makes ammonia. In the setting of acidemia, the kidney is working, the kidney is doing its job. The hydrogen acceptor is ammonia, which is NH3. It accepts the hydrogen and it becomes ammonium. Ammonium becomes trapped in the urine because it's a charged particle. And this is where that you're seeing that minus 20 because you're not measuring this. So all you were measuring was this, and this. Hence this negative gap, which in real life does not exist, but because we never measured it, we're seeing a negative. Okay? So case 1, describe the acid-base disturbance that was present. We said a non-gap metabolic acidosis with respiratory adaptation. Okay. What is the likely cause of the clinical acid-base disturbance afflicting this patient? Metabolic acidosis due to diarrhea. Okay. And the clinical scenario makes sense. Why? Because you had a non-gap metabolic acidosis, right? Diarrhea causes a non-gap metabolic acidosis, and your urine anion gap was negative. So the clinical picture makes sense. So in each question, we will be solving it like this so that this clinical scenario makes sense with the the clinical picture in itself. Now, management and treatment of this, obviously the patient is having diarrhea. We will have to kind of figure out whether there is an underlying infective issue, osmotic issue, secretory issue, whatever else the patient may be suffering from, depending on if it is infective, do they need antibiotics or not? If it is osmotic, are they taking something that is causing them to have diarrhea? Are they having a secretory issue due to a primary like celiac disease or some other disease that might be causing them to have tons of diarrhea? Depending on that, you'll use antibiotics, you'll cut out the agents like dairy products, or you might have to give them Imodium. Once the diarrhea goes away, the acidemia will go away. And during that time, you can supplement with oral bicarbonate. If they cannot take oral bicarbonate, you will replete with IV bicarbonate. So either or, the treatment would be twofold. And hence, you will get to the management and treatment of this metabolic acidosis based on your workup of the patient's previous situation. Okay. You cannot initiate any of this without working the patient up in the question above. Question number 2. 19-year-old patient found intoxicated in the bathroom of a high school dance. Emergency department found the patient's Glasgow Coma scale to be 6. Patients had alcohol in their breath. There were needle track marks on the right forearm. Their blood pressure was 149/94, heart rate of 76, respiratory rate of 5, temperature was normal. There was no focal neurological abnormalities. Okay, now, just like we did the previous question, we're going to do this question as well. Let me just turn on my pen. So, first and foremost, is this acidemia or alkalemia? Less than 7.4. Just grab a piece of paper and pen, put it next to you, and you should be able to just write down on yourself with your pen whether you think this is acid or alkali. In my opinion, this is acidemia because this is less than 7.4. The next question is, are the lungs trying to help or not? And in this scenario, unfortunately, the lungs should be blowing off carbon dioxide, and over here they are holding on to carbon dioxide, in fact, retaining carbon dioxide. Normal PCO2 is 40. This patient or this individual is sitting at 60. So they are sitting on extra molecules of carbon dioxide. So this makes it a acidemia based on the pH, and it makes it a respiratory issue because of the PCO2. So we will go down the route of respiratory acidosis. So this particular situation is a respiratory acidosis. Now, in order to work this patient up, obviously we looked at the numbers that we have. We have a pH of 7.2. We have a PCO2 of 60 and a bicarb of 26. So first and foremost, we'll call it acidemia because of the pH of 7.2. We will call it respiratory because of the PCO2 of 60, as we discussed in the previous slide, which makes it a respiratory acidosis. Now, given the clinical scenario, okay, this is not a patient with a 40-pack year history of smoking. So we will use this conversion or this factor in solving this particular question, okay, because we're thinking of an acute scenario. Other scenarios that you can think of where this kind of an acute scenario might have arisen would be a toddler swallowed a foreign object. Okay. Somebody is in a restaurant and unfortunately is choking on a piece of food. These are all acute events. Okay. So in that scenario, we will call it acute. So for every 10 rise of PCO2, your bicarb increases by 1. Okay, normal PCO2 is 40. Patient's PCO2 is sitting at 60. So the patient is 20 above their normal. The bicarb should go up by 2. If 10 makes it rise by 1, for 60 should make it go up by 2. It's simple ratios. So patient's bicarb is at 26. Normal bicarb is 24 plus 2, 26. So the patient is appropriately adapting it himself to this particular scenario. Yep, that is all there is. So this is appropriate respiratory adaptation. The metabolic compensation. So the primary disorder is primary respiratory acidosis with metabolic compensation. What is the likely cause of this patient affecting? So some kind of a respiratory issue has arisen in this patient. The reason why I'm saying this might be due to a sedative and hypnotic is because of the fact that the patient had alcohol and they had needle marks on their forearms as well, which means some kind of narcotic might have been used. And for that, we will consider this to be a respiratory issue. So in order to treat a patient with acute respiratory acidosis, you first have to figure out what kind of issue they are suffering from. And the issue that they may be suffering from might be a central CNS depression, a neuromuscular disorder, an airway issue, a chest wall issue, pleural. I mean, all these issues are there. However, your clinical acumen and your clinical history for the patient will help you determine what the patient is going through. Okay, you do not develop a neuromuscular issue out of nowhere, right? So if your patient was working in a farm or a field and they were using pesticides, you can think organophosphate poisoning, right? So the treatment will be totally different. This gentleman was found, this individual was found in a high school bathroom with needle marks and alcohol on their breath. So the likelihood of them using something that might have been central depressant in the form of either heroin or opium or something like that is higher, plus the added effect of alcohol as well. If this gentleman was sitting at the dinner table and eating and started choking, you think something has happened. If they were in a car crash, you would think there's a chest wall issue, right? All these different situations will give you different treatment management. So in this particular case, the patient will be given what is called a CNS stimulant in the form of Narcan or naloxone. Naloxone is an opium derivative that is available in the market. It may or may not be available in every institution. Sometimes we don't even carry it. But this is something that can save this patient's life immediately. So the naloxone that will be administered by EMTs or EMS, which is the emergency medical services, will improve the patient's respiratory status. If this patient had or was choking on something, you would then basically perform the Heimlich maneuver. If they have a neuromuscular issue, the treatment for organophosphate poisoning would be different than myasthenia gravis, than polio, than all this other stuff that you're seeing. But in this scenario, the clinical picture is of primary respiratory acidosis secondary to CNS depressants. Let me just quickly look at. Okay, number 3. This is a patient. The patient is 32. The patient is suffering from iron deficiency anemia and has pica. Pica is a syndrome or a scenario where, due to iron deficiency, people have an appetite for unusual substances. Okay, pica can also arise during pregnancy. So during pregnancy, depending on, and this doesn't happen to every individual, but in some individuals, they have a sudden craving for stuff that they have never wanted or liked in their life, and that is called pica. That pica is easier to solve and take care of, because once the pregnancy is over, their pica goes away. Iron deficiency anemia also plays havoc with the appetite center in the brain, and hence it can cause pica as well. Again, it doesn't happen in every individual, but it can happen. So this particular individual has this unusual appetite for substances. Pica is not just for baking soda. Pica can be for clay, for mud. Pica can be for ice chips. So it basically is stuff that normally you would not see somebody eat. So in this particular instance, they're eating about 10 to 12 tablespoons of baking soda a day. They got their lab work done, and lo and behold, their bicarb in the blood is sitting at 34. Okay. Their arterial pH is 7.52 and their PCO2 is 46. So is this acidemia or alkalemia? Grab a piece of pen, grab your paper, and just write down. Is this less than or greater than 7.4? If it is greater than 7.4, the answer automatically is this is alkalemia. And since this is alkalemia, we will call this alkalemia. Understood? Now, next thing is, because the blood is alkalemic, should the lungs hold on to acid to neutralize the alkali, or should they be blowing off acid and creating a problem for the patient? Simple question. There are no tricks about it. Your patient's blood is already alkaline. How do you neutralize an alkali? You add acid to it. The best way to add acid in the body is to utilize the best system and the quickest system that you have. Normal PCO2 is 40. Is this patient holding on to acid to neutralize the alkali, or are they blowing it off? And the answer is that they're holding on to the acid in order to neutralize this alkali, which means this is a metabolic issue. Okay, so again, that question that we had discussed, we will always be repeating it over and over again. We are not getting marks for originality. We need to get to the right answer. So in order to get to the right answer, the same question will be asked in every question that we're going to do. And that question is, what is the pH? What is the PCO2? And is the lung helping or creating a problem? And based off of that, we will jump into either a respiratory or a metabolic issue. Okay, so over here, we're dealing with a patient with a pH of 7.5, PCO2 of 46. And based off of this, we're calling it alkalemia. And because of this, we're calling it metabolic. And again, through the cheat sheet, which will be provided to you in the beginning, I'm going to put these cheat sheets down here. For every 10 rise in bicarb, the PCO2 should go up by 5 to 7. Okay. Now, in this particular patient, normal bicarb should be 24. The patient is sitting at 34, which is 10 higher than normal. Okay. The difference between these two is 10. So for every 10 rise, the PCO2 should go up by 5 to 7. Okay. Patient's bicarb normally should be at 40. Patient is sitting at 46, which falls within the range that we want them to fall in. This means the patient's PCO2 is appropriate. Okay. So for case 3, metabolic alkalosis with respiratory adaptation is the answer. Okay. What is the likely cause of the clinical acid-base disturbance afflicting this patient? The metabolic alkalosis is secondary to the bicarb consumption. It's clear as day. Sometimes you won't even need to do all of this, but for purpose of working patients up, we're going to be doing this repeatedly. Okay. The respiratory part is appropriate. How will you treat the patient in this scenario? The treatment for this particular patient, not for all patients with metabolic alkalosis, would be to treat the underlying iron deficiency, which will automatically cure the pica. And their ability or their want to eat bicarb is going to go away as you treat their iron deficiency. Now, this is an entire laundry list of causes of metabolic alkalosis. Okay, it can occur in vomiting. Okay, so in this particular scenario, what will we do? We will give patient antiemetics so that they don't vomit. If there is loss of excessive hydrogen in the form of, because we were using too many diuretics, we will cut down the diuretics, right? If there is severe hypokalemia, you will treat the hypokalemia. So each and every different situation will be treated differently. This is not a one-size laundry list fits all. So, however, the only way you'll get to this is working the patient up. So the fact that you were able to figure out this patient has metabolic alkalosis help you rule out respiratory alkalosis, respiratory acidosis, and metabolic acidosis. And that in itself narrowed down the list of differentials that you have. And then you went back to the clinical scenario in itself and saw, oh, the patient has iron deficiency. They're eating a lot of bicarb. All we have to do is treat the iron deficiency and treat the bicarb. If the patient was on a ton of diuretics, you would say, my friend, your diuretic dosing is inappropriate. We need to cut it down, and the metabolic alkalosis will get better. If they were suffering from severe hypokalemia, either because of diuretics or because they were vomiting, you would not only treat this or this, but you would also treat this by giving them potassium, either orally or intravascularly, and that will correct the issue in itself. So the only time and the only way you got to this particular scenario of I need to treat my patient is because of the fact that you were able to work up the patient and figure out that they have metabolic alkalosis. Okay. Now, here is a case of a 55-year-old individual. They are admitted for altered mental status and abdominal pain. Okay. Which means they can't give you much history. And this happens sometimes, right? So same situation. We will be solving this question the same way we've solved each and every other question. We will look at the pH. We will look at the PCO2. We will look at the sodium, the chloride, and the bicarb. Okay? And we'll solve it like we did every other question. So, is the pH acidemic or alkalemic? Oops, sorry. Simple stuff. Answer to yourself. Okay? The reason for doing this exercise is so that you guys get comfortable with looking at. So all these extra numbers don't mean anything. They are just there to confuse you. And even in the boards and even in other questions, what happens is you see all these numbers and you get overwhelmed. Oh, I have to look. No, all you do, pick your 5 numbers. The 5 numbers are your pH, your PCO2, your sodium chloride, and your bicarb. That's it. Then the next step is looking at the pH. You say acidemia or alkalemia. pH less than 7.4 is acidemia. So this patient has acidemia in their blood for whatever reason. Second question that we ask ourselves, are the lungs trying to help or are the lungs creating a problem? If the lungs were creating a problem, the patient's PCO2 would be greater than 40. Over here, they're actually down to 3029, which means the lungs are trying to help, which means this is a metabolic issue. Okay? Because this is a metabolic issue, we're going to call this metabolic acidosis. Because we are calling it metabolic acidosis, the next step is to figure out whether there is a gap or no gap. And because we need to figure this out, we will take the positives, which is 130, and subtract all the negatives from it, which is 94 plus 14. And we end up with, sorry, I'm going to use my calculator here because my math is horrible. 130 minus 94 minus 14, and you're left with a gap of 22, which means you have a high anion gap, metabolic acidosis. So the nomenclature for this scenario is high anion gap metabolic acidosis. Okay, it's as simple as walking through that entire schema. Okay, you do not have to jump to the answer completely immediately. Take your time. It is necessary to work these patients up appropriately because based on your workup is only when you'll be able to treat the underlying disorder. Okay, that cartoon that I showed right in the beginning of SpongeBob saying I have high metabolic acidosis is not going to be true in any scenario, shape, way, or form. We are going to have to work these patients up. And the only way to work them up is to look at what they're dealing with, what they're suffering from, or what their labs are showing. So now that you work them up and you found that they have a gap metabolic acidosis, gap, high anion gap, metabolic acidosis, your differentials are going to fall in that category of what causes high metabolic acidosis. And that way you can figure out what's the next best step in order to treat your patient, okay? This is the mathematical portion of everything. We already figured this part out. From a respiratory standpoint, remember, we have to use the Winter's formula. when it comes to using Winter's formula, 1.5 times bicarb, and the bicarb is given over here at 14 plus 8 plus minus 2. And the answer is 29 plus minus 2, which the patient is sitting at 29. So the patient is in respiratory adaptation. Now, because this was a high anion gap situation, unfortunately, we are forced to do what is called delta-delta. So let's do delta-delta. So here is your normal bicarb in the blood. Here is your gap or normal gap. Patient's gap is at 22. So answer or question yourself, how many molecules of acid added? And the answer is 10. 22 minus 12 is 10. That's the only way you'll get to a gap of 22, which means in order to neutralize 10 molecules of acid, you would have to use or neutralize, you would have to consume 10 molecules of base, and they will be utilized or neutralized from this particular bicarb. So your bicarb should be sitting at 14, or your patient's bicarb should be sitting at 14. Where is the patient's bicarb in this question? And the answer is 14, right up here. So this is an appropriate drop in bicarb based on a rise in gap. And hence you're going to call it a gap metabolic acidosis. And the delta-delta proves that there is no underlying disorder. Okay. The other way you can do this is, here is the gap. Here is the 10. The gap that was created as a result of the rise. 12 is normal, 22 is high. So the gap was 10. If you add the bicarb to it, which is 14, which was sitting in your question in itself, you end up with 24. 24 is normal, and your patient does not have an underlying secondary disorder. Okay. So this patient only has a gap metabolic acidosis. And like we said in the rules, gap metabolic acidosis, you have to calculate a delta-delta to understand whether there is an underlying non-gap issue in the patient. So moving forward, this is the other way of doing it. Okay, the difference was 10 plus 14, like over here, 10 plus 14 gives you 24. And so no underlying disorder. Let's move forward. So case 4 describes an acid-base disturbance. Okay, so we're going to say it's a gap metabolic acidosis with respiratory adaptation. And what is the likely cause? The reason why I said mud pies, this is one of the mnemonics that we use. You can use any of these, doesn't matter. As long as you have a high anion gap metabolic acidosis, you can say the patient, and then you can basically figure out, is it methanol toxicity? Is it uremia? Is it DKA? Is it iron? Is it lactate? Did they consume any ethylene glycol ethanol? Did they take extra aspirin? So there's a bunch of stuff that we can automatically figure out on these patients. Okay, whether you use this one, whether you use this one, whether you use this one, doesn't matter. But the fact that you work the patient up from the fact that they had acidemia, that they had a metabolic issue, that they had a high gap, tells you that this is what you have to use. And you don't have to worry about respiratory acidosis. You don't have to worry about respiratory alkalosis. You don't have to worry about non-gaps. Why? Because you already worked up the patient and you found that this is what they have. So now your differentials are limited to this. And now you can start working the patient up for what kind of an issue do they have. So if they have lactic acidosis, which is a blood work or a blood lab, you can figure out what kind of lactic acidosis they have. What if they have bowel ischemia, limb ischemia? In order to treat bowel ischemia, limb ischemia, because it is a perfusion mismatch, right? Not enough oxygen getting to where it needs to get to, and the body respiring anaerobically. In anaerobic respiration, the body will make what? Lactic acidosis. So this is called type A lactic acidosis. Once perfusion is corrected, bowel ischemia goes away, limb ischemia goes away, and the lactic acidosis will be neutralized because oxygen is getting to that particular location. Type B lactic acidosis could occur as a result of not enough ability to respire aerobically because there is a mitochondrial toxin. For example, metformin. In metformin toxicity, everything is normal, meaning to say there is enough blood supply everywhere. However, the body is unable to aerobically respire because the mitochondria are damaged. And because the mitochondria are damaged, you are pushed into doing anaerobic respiration. And what do you produce when you do anaerobic respiration? You produce lactic acid. So once you get rid of metformin from the body, you will then automatically be able to respire aerobically and the lactic acidosis will go away. So that would be the treatment for lactic acidosis. From alcohols, methanol is converted into formic acid and your patient may have a visual disturbance. Ethylene glycol, oxalic acid, and your patient may develop renal failure. You might even see these in the urine. These are envelope-shaped crystals. These are calcium oxalate crystals. So in the right setting, if a patient has unfortunately consumed what is called coolant or engine coolant or liquid coolant, which is basically used in cars to keep the engine cold or the engine to prevent from overheating, they can develop ethylene glycol or methanol toxicity. And the treatment is dependent on, so here's the fun part. You can actually use regular alcohol to prevent these two from being converted into formic acid or oxalic acid. Regular alcohol, which is ethanol, has a higher affinity for alcohol dehydrogenase. So if there's enough alcohol in your circulation or your patient's circulation, automatically that enzyme will go after alcohol and these two will be left alone and your body will basically urinate them out. And you won't convert them into their toxic metabolites, which is oxalic and formic acid. So your patient will be safe. The other way to do it is basically block ADH. This is not antidiuretic hormone. This is alcohol dehydrogenase. Alcohol dehydrogenase inhibitor is fomepizole. Not all hospitals have it. We don't sometimes carry it either. So alcohol, and this is going to be a high spirit alcohol. This is not going to be beer. This is going to be, shall we say, rum, vodka, whiskey. So your patient's probably going to love you for it. Okay? You can even drink some with them if your hospital allows. If these two are not there, the next step is dialysis. Dialysis will definitely get rid of all the alcohols. Now, for the boards, remember there is one question that everybody is asked. Isopropyl alcohol. Isopropyl alcohol never gives you an anion gap. And the reason as isopropyl alcohol does not give you an anion gap is because itself it converts into another osmole, and that osmole is acetone. So it goes from one osmole to another. And when it goes from one osmole to another, there is no anion gap. So basically the body breathes the acetone out. It is not removed in your urine or at any other location. So this is your board question. If you see a patient with a high osmolar gap and no anion gap, and they have consumed some kind of alcohol, it is an isopropyl alcohol. Isopropyl alcohol is basically rubbing alcohol. What is rubbing alcohol? Rubbing alcohol is what we use to sanitize our hands, to sanitize surfaces, any hospital setup where you have your, hand sanitizers. This is basically isopropyl alcohol, okay? So if a patient gets a hand of this, they can potentially, some people actually have an addiction to it. They like the flavor, they like the smell, they like the taste. And so they can show up with isopropyl alcohol toxicity as well. So remember, it will not give you an anion gap. It will only give you an osmolar gap because it converts from isopropyl alcohol to acetone. Now, diabetic ketoacidosis and SGLT2 inhibitors, these are medications that are recently on the market to curb and treat diabetes. In diabetic ketoacidosis, what has happened is that the patient, for whatever reason, either missed their insulin doses, and because they don't have insulin, there's no way for sugar to enter into the body or into the cells that it needs to enter into. So the body is using acetone and beta hydroxybutyrate to provide itself with energy. In order to treat DKA or diabetic ketoacidosis, you first hydrate the patient with tons of fluids, and then you give them insulin, and the gap goes away, or the diabetic ketoacidosis is resolved. When it comes to SGLT2 inhibitors, what is unfortunately happening is if you are a type 1 diabetic and your sugars are down to 120, what ends up happening is, out of a habit of mistake, patients are like, oh, my sugars are good, I should hold my insulin. And what happens is, because they hold it or they stop their insulin because they saw good blood sugars, thinking that quote unquote, I've been cured, they go into this situation. So with diabetic ketoacidosis, obviously your sugars can be 700, 800. In SGLT2 inhibitor toxicity, your sugars may be 120, 130. And what ends up happening is your patients then end up in the same situation. They produce acetone, they produce beta hydroxybutyrate. What you do for them is you basically do the same thing, but you have to discontinue the medication as well, which would be the cornerstone. And then you educate the patient that just because your sugars got better doesn't mean that you stop your insulin. Yeah. Those medications that come by the name of floglosin, for example, dapafoglozin, canifoglozin, empafoglozin, are all type SGLT2 inhibitors, sodium glucose type 2 transporter blockers. Okay, so these are all proximal tubular blockers that stop the sodium and the glucose from being absorbed. Sugars drop, patients do a lot better. Okay, next, this is the last case in the series of single disorders. We haven't gotten to double, we haven't gotten to triple. So single disorder, this is the fifth in a series of questions. 20-year-old, altered mental status, combative, spewing profanities. Okay, we are called because the right arm contraction, the patient's right arm is contracted like this. For those of you who've clinically seen this, you already know what's happening with this patient. It only happens when the BP cuff is inflated. And when it happens, the patient unbeknownstly already is a little freaked out, but freaked out even more because they have no control over their body. Okay, you check the patient's labs. Ionized calcium has dropped. Total calcium, normal. ABG showing a pH of 7.55 and a PCO2 of 40. Okay, same condition, same situation. Just like we've solved every other question, we're going to solve this one the same way. 7.55. Acidemia or alkalemia? Think of it and write it down. Is it greater than 7.4? The answer is yes, which means this is alkalemia. Okay? Now, because your blood is alkaline, or your patient's blood is alkaline, should the lungs be holding on to carbon dioxide, or should they be blowing off carbon dioxide? And the answer is they should be holding on to carbon dioxide to neutralize this. So the PCO2 should be greater than 40. Unfortunately, in this patient's case, the PCO2 is sitting at 20, which means it's a respiratory issue. Okay? So you're going to call this respiratory alkalosis or respiratory alkalemia. All other differentials are down the drain now. You don't have to worry about gap metabolic acidosis. You don't have to worry about respiratory acidosis. You don't have to worry about any of that stuff happening. Why? Because you've already labeled the patient as having respiratory alkalosis. Okay? So with that being said, I'm going to rub some of this out so that we have some clarity over here, because some of the stuff is going to pop up at this corner. So we said alkalemia because of the pH being greater than 7.55. We said respiratory because the lungs were not holding on to the carbon dioxide. And this is the cheat sheet that we were showing in the previous situation as well. So in this particular cheat sheet, we're going to be using this. Okay. Again, the patient does not have any chronic issues that are isolated in the question itself. Please remember, your questions will tell you whether this is an acute or a chronic process. Do not assume on your own. This patient is not having any chronic issues that are isolated or informed to you in the question itself. If it's not, you don't assume on your own that this is a chronic situation. So you will use this particular cheat sheet, which is an acute respiratory alkalosis. And the way to verbalize this is that for every drop of 10, your bicarb drops by 2, meaning that your kidney lets go of 2 molecules of bicarb. It is easier for the kidney to slow itself down because it can adjust the enzymes. It's difficult for the kidney to generate 2 than to let go of 2. So this occurs a lot faster. So your patient's bicarb is sitting at 20. Your patient's PCO2 is sitting at 20. So normal PCO2 should be at 40. Patient's down to 20. So for every 10 drop, you should be down by 2. So this would be the first 10. This would be the another 10. So your patient should be down by 4, which means normal bicarb that should be at 24 is now down to 20. And where is your patient's bicarb? 20. Okay. So this workup checks off everything that we're seeing. The kidney is responding appropriately to the drop. This mathematics that you've done is to prove that the patient is appropriately adapting from a renal standpoint. Okay. So the reason why we use 2 plus 2 is because for every 10, you go down by 2 right here. Every 10, you drop by 2, which is the ratio over here. And because the patient dropped by 20, this is the first 10, this is the second 10. So they went down by a total of 4. Normal bicarb is 24. The patient should be at 20 and the patient is at 20. And hence your answer is correct. So your patient is suffering from respiratory alkalosis with metabolic compensation or adaptation. Now, what caused this particular situation? It is caused secondary to hyperventilation. Okay. And the reason why I'm saying this is because of what you found over here. Total calcium being normal, ionized calcium being low. The relationship of alkalemia with calcium. Remember, alkalemia of any kind makes albumin more negative. When albumin becomes more negative, it traps more calcium. So in patients who hyperventilate, they can show you signs of tetany. But when you check their total calcium, it will be normal. So the ionized calcium goes down. Why? Because more calcium got trapped by the albumin. In this patient, which is a true story, the patient unfortunately had done LSD for the first time. And because of that, they basically had never seen the effects or never had experienced the effects of LSD. And that caused them to freak out. And because of that, they were hyperventilating. And in hyperventilation, because the patient had alkalemia, it caused a drop in the ionized calcium, even though the total calcium was normal. Okay. And the cough, the problem that you were seeing on the contracture in the arm is called Trausius sign. Okay. It's a clinical sign that you see when a blood pressure cuff is applied to a limb of the patient. If you had applied it to the leg, their leg would have contracted the same way. You can also do what is called Shivostic sign, which is basically tapping the facial muscles, and the patient will have a muscular twitch on their face, all showing hypocalcemia. Okay. Now, how do you treat hyperventilation? Hyperventilation or respiratory alkalosis can occur because of all of these. Okay. You can have psychogenic, which is basically regular run-of-the-mill hyperventilation. It could be because of altitude. It could be because of PEs, pneumonia. Could be due to mechanical ventilation because the settings on the ventilator were too fast. It could be due to congestive heart failure. Each one requires a different treatment. If it's congestive heart failure, you diurese them. If it's mechanical ventilation, you basically tone down the tidal volume on the ventilator. If it's pneumonia, you treat the pneumonia with antibiotics. It's PE, you basically treat them with anticoagulation. So each one will require a different treatment modality. When it's psychological or psychogenic, this is what the patient is doing, okay? You want them to slow down. So in order to do that, you basically ask them to blow into a paper bag, okay? What I normally hear people say is, reduce, they need to blow into, they need to basically breathe their own carbon dioxide. This is not the right way to make somebody stop hyperventilating. So cartoon number 2, good. Cartoon number 3, bad. Okay, this is basically that we're done with single disorders. We will start with we're done with single disorders. We will start with double disorders now. So identical cases, we'll just work them up the same way that we have been working up all the cases before, okay? This is a 22-year-old patient with type 1 diabetes, presents to the emergency department. 1-day history of nausea, vomiting, polyuria, polydipsia, vague abdominal pain, noted to have deep sighing breaths, orthostatic hypertension, dry mucous membranes. Patient sodium is 134, potassium is a little high, chloride 93, bicarb 11, glucose 720, BUN 138, creatinine 2.6. Measured osmolality is 320, calculated osmolality 318. This is the urine analysis. This is the ABG. So, as you can see, stretched out question, looks long, freaks people out. Where do we start? Again, same stuff, my friends. We're going to start exactly where we always start. We start with circling the 5 numbers that we need: the pH, the PCO2, the sodium, the chloride, and the bicarb. Okay. Now, use your piece of paper next to you. Patient's pH is 7.25. You do not need to be a rocket scientist to answer this one. Less than 7.4 or greater than 7.4. This is definitely less than 7.4. So you will call this acidemia. Perfect. Good. Next question. Are the lungs trying to help or create a problem? i.e., are they holding on to acid or not? Normal lung acid levels or carbon dioxide levels are 40. This patient is sitting at 25, which means the lungs are trying to help the patient by blowing off extra acid, which makes this what kind of an issue? Metabolic issue. Okay? Now, since we've called it a metabolic issue, the next step is to do what? We have to calculate a gap. Okay? Again, the same stuff that we did for all the other metabolic questions, we're going to do here as well. Right? This is not an exercise of originality. This is an exercise of repetitiveness. This is what we will have to do for each and every question every time we see a patient with this situation. How do you calculate a gap? You take all the positives, you take all the negatives, you subtract the negatives from the positives, and you will end up with your answer. So over here, all the positives are 134, all the negatives are, if I'm not mistaken, 104. Please correct me if I'm wrong. The answer should be around 30. So this is a high anion gap metabolic acidosis. Okay. Again, I'm not tricking anybody. This is what the numbers are showing. Okay. Because you've said, and because we've worked it up, that the pH is less than 7.4, this is acid. Because the lungs are trying to help, this is metabolic. And because of the math saying that there is a gap, there is a gap. We're not making stuff up. This is reality. Okay. Math does not lie. So this patient has a high anion gap metabolic acidosis. Okay. So your differentials are now limited to gap or high anion gap metabolic acidosis, which include lactic acidosis, alcohol intoxications, diabetic ketoacidosis, and all the other fancy stuff that kind of goes in that bucket. Okay. But this is how we work patients up. Okay, so next step. Again, we're looking at this 7.25. We're looking at this. We're looking at a bicarb of 11. Okay, so we said acidemia. We said metabolic. We said gap because that's what the gap is showing. Okay. Adaptation wise, since this is metabolic acidosis, we will apply what is called Winter's formula. For all GAP and non-GAP metabolic acidosis, we will use the same formula. There is no different formula for GAP versus non-GAP. Winter's formula stays the same. 1.5 times bicarb plus 8 plus minus 2. Where do you get the bicarb from? The bicarb is given right here at 11. So once you substitute that 11 over here in the formula, you will end up with 1.5 times 11 plus 8 plus minus 2. You're left with 24.5 plus minus 2. And the patient's PCO2 is where? 25. That's exactly where the patient should be. So the patient is compensated respiratory wise. Good. So unfortunately, we have to do the delta delta for this one. So in order to do the delta delta, we're going to do what I normally do by drawing it out. You can do the mathematical one as well. Oops, sorry. You can do the mathematical one as well. You can do whichever one you like. I am more of a visual person, so I like to draw things out. So here, oops, sorry. My bad. I'm going to do the thumb. Here's the pen. Okay. Normal bicarb is 24. Normal gap is 12. Okay. Don't worry about what's showing up on the slide itself. Just follow what I'm writing down right now. We calculated the gap at 30. So in order for a patient to receive or get to a gap of 30, how many molecules of acid need to be added? 30 minus 12 is 18. Simple stuff. This is all math. Okay. Nobody's cheating you. Nobody can cheat you. Nobody can trick you. This is all regular run-of-the-mill math. Okay. If you have added 18 molecules of acid, then by virtue of 18 molecules of acid being added, 18 molecules of bicarb should be consumed as well. So in order for 18 molecules of bicarb to be consumed, your bicarb should be sitting at somewhere around 6. Where is the patient's bicarb? 11. So patient has extra molecules, 5 extra molecules of bicarb. Okay, which means they have an underlying metabolic alkalosis. And that's how you use or utilize your delta delta to help figure out whether they have an underlying disorder or not. This is the first time we're doing it. I will repeat this one more time. Okay, I'm going to erase all of this and we're going to walk through it one more time. And the reason for doing this over and over again is because this way it'll stick, or at least you guys will be able to solve it on your own again as well. Okay, so 24 is the normal bicarb. 12 is the normal gap. 30 is what we calculated for the gap to be. In order for a patient to get from 12 to 30, how many molecules of acid added? 18. 18 molecules of hydrogen molecules are added. Okay. Now, in order to neutralize these 18 molecules of acid, by virtue of simple math, 18 molecules of bicarb should be utilized as well. So the patient's bicarb should be sitting at 6. Simple math. What goes up over here should come down. What goes up over here should come down over here equally. Right? However, our patient is sitting pretty at 11. Why is the patient having more molecules of bicarb? The patient should be at 6. The patient's at 11, which means they have 5 extra molecules of bicarb, which means they have an underlying metabolic alkalosis. Okay. And congratulations, everyone. This is your first dual disorder that you have solved. Okay. Now, how do we corroborate this with clinical workup? Let's do it clinically. Okay. So we have said that the patient has a gap metabolic acidosis. and a metabolic alkalosis. Now, the reason why we're putting gap metabolic acidosis before metabolic alkalosis is why? What was the first rule of solving acid-base disturbances? The pH determines the primary disorder. The patient's pH was 7.25. Hence, the primary disorder comes first. Okay? And the secondary disorder comes second. Okay? You cannot say patient has metabolic alkalosis and gap metabolic acidosis. So that's why gap metabolic acidosis is first in the nomenclature, followed by the metabolic alkalosis part, and then you have your respiratory adaptation because we calculated the winters. Now, why do they have these two? Because there are two disorders that are occurring in the patient. The DKA is causing the gap metabolic acidosis, and the patient showed up vomiting, which means they lost hydrogen, which is causing the metabolic alkalosis. So again, the clinical picture fits your mathematical workup as well. These are actual real cases, and this is how the patients present, and this is how you will work them up. So your treatment for a patient like this would be what? The DKA part will be treated exactly like you would treat any other DKA. Fluids, IV insulin. But for the vomiting part, all you have to do is make sure that the patient does not continue to vomit. As their antiemetic, you can utilize any antiemetics that you need. Once they are not vomiting, life is good, and their metabolic alkalosis will go away as well. Okay? And you have solved your first dual question. Next, we're going on to case 7. Case 7 is that of a 55-year-old patient admitted with complaints of severe vomiting for 5 days. They have diminished skin turgor. These are their blood work. Okay. Now, again, this is huge. This is, they can be stretched out as well. They'll give you a bunch of primary history, all that stuff. The focus should be on your 5 numbers. Again, sodium, chloride, bicarb, pH, PCO2. Okay. Of everything that you're going to do, you're going to isolate these few. pH is 7.23. Sorry. Which means this is acidemia or alkalemia. It's less than 7.4. This is acidemia. Next, PCO2 of 22. Lungs are trying to help. So this is a metabolic issue, not a respiratory issue, which means your nomenclature is metabolic acidosis. Because it's metabolic acidosis, the next step is to calculate what is called a gap. And in order to calculate a gap, you're going to take all the positives, subtract all the negatives, which is 77 plus 9. And you are sitting on a huge gap of, shall we say, 40 almost, question mark, if not more. My math is horrible, but looking at it, it looks like it's a high anion gap metabolic acidosis. Agreed? So since this is a high anion gap metabolic acidosis, the nomenclature will be that this patient has high anion gap metabolic acidosis, and it is evident by the fact that your patient's lactate is sitting at 10. Okay, so the clue is right there in the question in itself. Okay, so workup, no different than what we did. Metabolic acidosis, high anion gap, almost 50. Sorry, my bad. Mathematics, the math doesn't lie. Adaptation, again, use your Winters formula, 1.5 times bicarb. Bicarb is 19 plus 8 plus minus 2. And you're left with 21 plus minus 2, which means 23.5 to 20 to 19.5. The patient is sitting at 23, so this is appropriate. Since this is a gap metabolic acidosis, we are mandated to do what is called the delta-delta, and we're going to do it the same way that we did with the previous question. We're going to do the math again. Okay, I'm more of a visual person, so I'm going to draw it out. 24, 12, this thing went up to 50. So how many molecules of acid added? Almost 38. Agreed? 38 molecules will get you to your patient to 50. Okay? Which means this should drop by 38 as well. Which means your patient should be sitting at negative 12 or negative 16 or something like that. Your patient is sitting at 9. Which means they have 12 plus 9, about 20 something molecules of bicarb or extra bicarb. So how is that possible? Because they have an underlying metabolic alkalosis. Okay. And that's how you do a delta delta. And that's how you will do a delta delta every time you have a gap metabolic acidosis on a patient. Okay. So you can draw it out, you can do it mathematically, whichever way you want. Okay. If you want me to do it mathematically, I can show that to you guys as well. Okay. Your gap was calculated at 50. Your patient normal gap is at 12. So that makes it 38. Okay. 38 plus 9 gives you 45. Sorry, my math is horrible, or 47, I don't know. But this is definitely greater than 24, which means it is a metabolic alkalosis as well. Okay, so both ways is how you can solve this question. Okay. If you are good with math, do math. If you are good visually, do visually. But at least you'll get to the same answer. Okay. Moving forward. So you've said gap metabolic acidosis, you've said metabolic alkalosis, you said respiratory adaptation. Again, metabolic acidosis came first. Why? Because the pH was 7.23. Primary disorders dictate your primary issue. What is the likely clinical cause of this acid-base disturbance afflicting this patient? Lactic acidosis from hypotension and metabolic alkalosis from the vomiting. Okay. And that's how you got to the answer. So the clinical picture matches the math that you're doing. And that's how you will treat either one by giving this patient fluids so that the hypotension goes away, perfusion gets better, lactic acidosis goes away. And for the vomiting part, what will you do? You will give them antiemetics. And over here is fluid resuscitation for the lactic acidosis. So again, each different kind of gap metabolic acidosis will be treated differently. This is case number 8. You have a 50-year-old patient. They have Sjogren's syndrome. They are following you for kidney stones. They also smoke for 40 years. They've had 3 stones in the past 4 months. Okay. See the number of numbers that they've given, which then makes it very overwhelming and daunting. Again, do the same things that we're going to do every time. pH, PCO2, sodium, chloride, bicarb. That's all you need right now. Okay. So pH is 7.3. Again, use your pen and paper. Is this less than 7.4? The answer is yes, which means this is acidemia. Okay. Are the lungs trying to help? Are they sitting at 40 or are they dropping down below 40? And the answer is yes, they've dropped down below 40, which means they are trying to help, which means this is a metabolic issue. Now, because this is labeled as a metabolic issue by you, you will call this a metabolic acidosis. Since you're calling it a metabolic acidosis, the next step is to calculate a gap. And in order to calculate a gap, you will take 136 minus 127. And how did I get to 127? I took 111 and I added 16 to it. So this is 127. And when you subtracted it from the 136, you're left with 9. So this is a non-gap metabolic acidosis. Okay. So your nomenclature will be patient has a non-gap metabolic acidosis. Okay. Now, in a non-gap metabolic acidosis, you do not calculate a delta delta. Okay. How can you have a gap when no gap exists? So your math stops right here. Do not trick yourself in trying to do a delta delta for a non-gap metabolic acidosis. It does not exist. Period. Now, since we've said non-gap, the next step is to figure out one of two things. We can do the Winters formula first, or we can do why is the patient sitting on a non-gap. Okay, both answers will get you, both routes will get you to the same answer. So let's start working the acidemia part first. So they have a acidemia because of the 7.3. It's metabolic because there's no gap, right? And because the gap was this 10 or 9, whatever it was, but it was a non-gap, right? I apologize, my math is horrible. Sorry, oops. Okay, so that's why we're not doing a delta delta. because we have a non-gap, what do? We look at the urine anion gap. It's exactly like a blood anion gap. The only difference is you're going to take the urine sodium, the urine potassium, and the urine chloride, and you're going to do what is called take all the positives to one side, take all the negatives in the other end, and you're going to left with an answer that is either going to be positive or negative. If this was negative, you would have said something's happening in the gut. But since this is happening in the blood, in the urine, and it's negative, it's positive, you're going to say the kidney is at fault. Okay, this is how I visualize a positive urine anion gap. The sodium was at 60, the potassium was at 10, the chloride was at 20. Okay, ammonia production is there, but it is reduced. However, the unmeasured phosphates, nitrates, and sulfates are what are accepting the hydrogen in this particular scenario. And hence, because we're not measuring this, we're not measuring this, all we were measuring is this, and we're subtracting it from this. This is what gave us the positive urine anion gap. This is this positive 50 that's showing up. It does not exist. We are not urinating a positive urine. Otherwise, it would hurt. It would be very painful because acid, a charged electrical compound being moved out of the body would be very, very painful. Okay. Now, this is where these renal tubular acidosis come into play. I'm not going to go into the detail of each and every one because they are cumbersome, and maybe we can do another lecture at some point on renal tubular acidosis. But for now, just remember, this is where type 1 renal tubular acidosis occurs. It is a problem in one of the cells, and that cell is called an intercalated cell. That intercalated cell cannot pump hydrogen into the urine, so your urine stays alkaline. Because your urine stays alkaline, you keep on making stones. So the acid stays in the blood and cannot be pumped into the urine because this cell is defective. Type 2 is inability of the proximal convoluted tubule to pump or reabsorb bicarb. And because you cannot reabsorb bicarb, you dump bicarb in the urine and hence you become acidemic. And the fourth one is the lack of aldosterone, secondary to the fact that the JG apparatus is diseased. And because the JG apparatus is diseased, you cannot acidify the urine again. Okay, so type 1 and type 4 is an acidification issue. Hydrogen cannot be pumped into the urinary lumen in adequate amount, hence acidemia in the blood because blood is sitting with a higher hydrogen concentration. Remember, our gut is not designed to pump out hydrogen. So the gut cannot take over for the acid that is building up in the blood. Okay? Hence, and because the kidney is at fault, the blood stays acidemic. So it's an alpha cell issue. The urine pH is alkaline. So think of it this way. When you have acid in your blood, your urine should be acidemic. Why? Because your body should be pumping out acid. The kidney should be helping get rid of the acid. If your blood is acidemic and your kidney is holding on to the acid and your kidney is not making an acidic urine, there's a problem in the kidney. Hence the type 1 renal tubular acidosis. And because the persistent alkaline nature of the urine, the patient makes stones throughout. Okay. So which type of renal tubular acidosis? Patient has hypokalemia in the blood. It's either going to be a type 1 or a type 4. 2. Type 4 is hyperkalemic. And because of acidification, type 1 cannot acidify the urine. Type 2 still can. So by virtue of elimination, the patient was hypokalemic, which is type 1, and the patient cannot acidify the urine, which is also type 1. This patient has type 1 renal tubular acidosis. Again, like I said, these are more detailed topics. I can go into the nitty-gritties of it, but that's not the cause, right? That's not the methodology right now. The methodology is for you to work up what a non-gap metabolic acidosis would look like, and that's what we're focusing on right now. Okay, so working through the question, we will look at Winter's formula, 1.5 times bicarb plus 8 plus minus 2. The bicarb of the patient was at 16. The patient should be at 32 or 30 to 34. The patient was sitting at, if I'm not mistaken, 36, which means they're holding on to more acid than they should. And if they're holding on to more acid than they should, that means they have a respiratory acidosis. So this is the first time you're seeing a respiratory acidosis along with a metabolic acidosis in a patient, okay? This is likely because of the fact that this patient has a long history of smoking as well. Let me confirm by going back on the slides. Yep, they had a 40-pack year smoking history. And so the clinical picture makes sense, okay? Again, this is all mathematical. You don't have to come up with these scenarios. The question will prove it to you that they have what they have, okay? So the acid-base disturbance is a normal gap or a non-gap metabolic acidosis secondary to renal tubular acidosis with respiratory acidosis. What is the likely cause? Renal tubular acidosis secondary to Sjogren's syndrome with respiratory acidosis secondary to the long-standing history of smoking that this patient has. The treatment will be treatment of the Sjogren's syndrome, okay, which is the antibody disease, and bicarb supplementation because the patient is acidemic in their blood, and you will give them bicarb and they will neutralize the acid, okay? Now, because of all of this, what I'm going to do is I'm going to jump over to the last question because that is more important than these because we've already done a type 2. And then we'll get on to the questions for the CME in itself because I want to give them at least 15 to 20 minutes at the end. So this is going to be our last case. So this is a 20-year-old patient found next to an empty bottle. This is a resident that is presenting the scale. The parents had brought in the bottle as well. So you identified and figured out what's the cause. The patient has D5W with 150 milliequivalents of bicarb running at 100 ml. The reason for that is you'll see in the question, the patient's sodium is at 147, potassium at 4, chloride at 100, bicarb at 10, BUN at 15, creatinine at 1.2, ABG 7.32, and PCO2 at 18. So I'm going to switch over here to my pointer and my pen, and we will solve this question together. So again, circling of the 5 numbers that you need. Sodium, chloride, bicarb, ABG, showing your pH and your PCO2. So based off of this, 7.32. Acidemia or alkalemia? Acidemia. Okay. Are the lungs trying to help? PCO2 is down to 18 from 40. Right? So this is, the lungs are trying to help. So this is respiratory. Agreed? Sorry, yeah, my bad. The lungs are trying to help. So this is metabolic. Does everybody agree? Okay, so since this is metabolic, and we've said metabolic acidosis, we are now mandated to kind of figure out whether there is a gap or not. And in this scenario, we will take 147 and we will subtract 120 for 110 from it. My apologies. As always, my math is horrible. The reason why we're doing 110 is right over here, 100 for the chloride, 10 for the bicarb. Okay, so 110 is the negative total that we're getting. So the gap is sitting at 137. Oh, sorry, 37, which means this is a high anion gap metabolic acidosis. Okay, because the gap was sitting at 37. So since this is a high anion gap metabolic acidosis, we will be mandated to do what is called the delta. Okay, so I'm going to grab my eraser again. I'm going to erase all of this and I'm going to draw out how it looks like to have or the gap delta that we're going to calculate for this question quickly. So again, same scenario. 24 is the bicarb. 10 to 12 is your normal bicarb. We're going to use 12. Normally, this is what is listed in most of our labs. The gap that you calculated was 37. Okay. In order to get to 37 from 12, how many molecules of acid do you need to add? You will say 25. 37 minus 12 equals 25. since you have added or your patient added 25 molecules of hydrogen to the body, there should be a compensatory drop of equal amount of bicarb as well, because each hydrogen will be consumed, or each hydrogen will consume one molecule of bicarb as well, which means your patient should be sitting at -1. Patient is actually sitting at 10, which means they have 10 plus 1 equals 11 extra molecules of bicarb, which means they have an underlying metabolic alkalosis. Okay, so here's where the delta helps out and comes into play. How will it equate to the patient's clinical picture? We will come to it when we get to the other part of it. Now, the third component, or the third thing that I have to show you guys, is the Winters formula. Okay. And for the Winters formula does not change for any scenario. Okay. This is metabolic acidosis. So it's going to be 1.5 times bicarb. Look at the bicarb. It's 10 plus 8 plus minus 2. Okay. So this is 15 plus 8 plus minus 2. So it should be 23. So the patient should be sitting at 21 to 25. Where is the patient? 18. Patient is blowing off more carbon dioxide than they should, which means they have a respiratory alkalosis. And we'll get to as to why. Remember, this patient consumed something. Okay? The consumption is what is causing all these issues. Okay? So this is your first patient that has a gap metabolic acidosis with metabolic alkalosis with respiratory alkalosis. I mean, think of it. They have a gap of 37. They have a huge gap. Yet their pH is sitting pretty at 7.3. So these two metabolic alkaloses are kind of sort of neutralizing the gap metabolic acidosis. Hence the pH being at 7.3. Otherwise, the patient may be sitting at 7.1, 7 even 6.9. Okay. Now, we will get to why this is the case. Okay. So the acid-base disturbance that we identified, again, primary disorder first, gap metabolic acidosis. Whether you put respiratory alkalosis second or metabolic alkalosis second, doesn't matter, but this is there and this is there. So the gap metabolic acidosis is because of consumption. Okay, they ate something, they took something, and we're going to figure out what. The metabolic alkalosis is because of the bicarb drip that the patient is getting. And the respiratory alkalosis is because of the consumption as well. Okay, so there is one scenario or one agent when consumed by the body, which is aspirin, that can cause this kind of a scenario. Okay, metabolic alkalosis secondary to, metabolic acidosis secondary to the consumption of aspirin, metabolic alkalosis due to the bicarb, and respiratory alkalosis because aspirin is a central nervous system stimulant. So it makes people breathe faster. Okay, treatment for aspirin toxicity is gastric lavage. You alkalinize the blood with bicarb drip. Hence, you have to actually give these patients bicarb drips. Salicylic acid cannot enter the brain if it is positively charged. If you alkalinize the blood, salicylic acid does not get in. So the toxicity, the neurotoxicity goes down. And if your patient is having an aspirin level of greater than 100 or neurological symptoms, you basically hit them with dialysis. You need to get the blood cleaned out. Okay. And that is the treatment for aspirin toxicity. And with that, I will complete my presentation so that I can give my screen back so we can do the CME questions.
Thank you very much, Dr. Hasan. That was a very interesting, engaging, and comprehensive lecture on acid-base balance disorders. So having said that, we'll directly proceed to the Q&A.
All right. So Dr. Hasan, we have a couple of questions that we have prepared. The first question says, what causes respiratory acidosis in newborns, and why does pregnancy cause respiratory acidosis?
So, I mean, the respiratory acidosis in newborns is one of twofold. One, the baby has never seen an aerial environment, right? For the longest part, for 9 months, the baby is basically in the maternal womb. They are being breathed, and their oxygen and their carbon dioxide supply is through the mom's umbilical cord. The first time they're taking a breath, their muscles are not developed and their respiratory drive is not there. And this is why or what causes respiratory acidosis in newborns. The longer they are exposed to that respiratory environment, the respiratory acidosis goes away. So that's why. Not that pregnancy causes it. It's just that the baby is kind of getting used to the environment as it is.
Okay, thank you very much. The second question reads, which is a physical assessment finding of respiratory acidosis, and how does asthma cause respiratory acidosis?
So this is an excellent question. Respiratory acidosis, asthma does not cause respiratory acidosis. Asthma causes respiratory alkalosis in the beginning. And the reason why that is when somebody can't catch a breath, what ends up happening is that you try to breathe faster. Okay. And if you try to breathe faster, you're going to be having alkalemia. And because you're going to have alkalemia, the patients with asthma, the majority of them show up with respiratory alkalosis. Now, if your patient is starting to develop respiratory acidosis in the setting of asthma, that is a worrisome sign. That means that they are going into respiratory failure. Remember, you can breathe fast for so long. So if your patient has respiratory acidosis in the setting of an acute asthmatic attack, that means they're going into respiratory failure. They need or may need either non-invasive breathing by BiPAP or CPAP, or they might need to be intubated. So keep an eye on that. Excellent question.
Okay, thank you for that. The third question reads, in case of psychogenic hyperventilation where hypocalcemia is present, is there any role for treating it with calcium gluconate?
So to tell you the truth, the calcium levels in your blood are normal. So you don't need calcium gluconate. All you need to do is bump calcium off of albumin. And the best way to bump calcium off of albumin is to correct the pH. And the easiest way to correct the pH is to make a patient breathe in a brown paper bag. Okay, it's the cheapest modality you'll have. And the quickest fix, because your correction for breathing is going to be faster because the respiratory conversion and compensation is quicker than you putting an IV in a patient and having to run calcium gluconate, which will be costly. And again, remember, your patient is not sitting on maybe like 1 or 2 liters. Calcium has to be distributed in 30, 40 liters of blood. So you're going to have to give a lot of calcium gluconate, right? So the thought process is the quickest fix and the cheapest fix. And a brown paper bag is definitely quicker and cheaper than calcium gluconate.
Okay, thank you very much. The fourth question we have says, what are the contraindications for sodium bicarbonate?
That is a very broad question, my friend. Is it in context to a certain situation, or is this okay. So I think what you mean. So sodium bicarbonate can be given to people who are in severe metabolic acidosis. Any patient who is in the ICU with a pH less than 7.1, you can give them sodium bicarbonate to correct their pH to about 7.1 to 7.2. If their pH is greater than 7.2, do not give them sodium bicarbonate, as it can create more alkalemic issues later on. Like I said, alkalemia is what's causing the calcium to be sequestered, right? Just like we did the question in psychogenic hyperventilation, it was alkalemia, not bicarb, alkalemia. So if your patient becomes severely alkalemic, whether it is because of respiratory or metabolic, your patient's calcium levels will drop. So If your patient is sitting on severe hypocalcemia or their pH is greater than 7.2, please do not give them any sodium bicarbonate.
Okay, thank you for that. The fifth question we have reads, does lactate ringers treat metabolic acidosis?
So, lactated ringers can be utilized for the treatment of metabolic acidosis. The more important question, or the question that one should ask themselves, is do they have a working liver? Okay, lactate has to be broken down into its what you call it. Lactate would be broken down into bicarbonate if you have a working liver. If you don't have a working liver, giving the patient lactated ringers is not going to achieve the goals that we need.
Okay, thank you for that. Question number 6 reads, can you elaborate more on relation of calcium to alkalosis?
Yes.
I think this is
So,
more of a general question.
yeah, and it's kind of linking up with the psychogenic hyperventilation situation. So, alkalemia. So, remember, albumin in the blood carries calcium. There is a 50-50 relationship. Your total calcium is bound by about 50% to albumin. So you have 50% ionized calcium and 50% non-ionized calcium. Hence, you get a total calcium value and an ionized calcium value. When somebody has alkalosis, albumin becomes more negative because it is a tertiary structure. So tertiary structures, and it is a protein. So proteins become denatured either in severe acidemia or alkalemia. And the way albumin behaves is that it becomes more negative when there is alkalemia in the blood and less negative when they have acidemia. So when somebody is undergoing a process of alkalemia or alkalosis, either because of a respiratory or a metabolic cause, it makes albumin more negative, and unfortunately it sucks or binds more ionized calcium to itself. Hence, there is less ionized calcium left in the blood. And since there is less ionized calcium left in the blood, unfortunately, it causes symptoms of hypocalcemia, even though your calcium levels are normal, because symptomatology of calcium is dependent primarily and solely on your ionized calcium levels. So that is the relationship of calcium with alkalemia.
Okay, thank you for that, doctor. The 7th question we have reads, how does administering bicarbonate supplement the treatment of DKA?
So ideally speaking, DKA would not require bicarb supplementation. The acid that is being generated as a result of a lack of an ability of the body to utilize sugar. As soon as your body or your patient's body starts utilizing sugar for its energy sources, the acetone, the acetoacetate, the beta hydroxybutyrate automatically go away. And if the beta hydroxybutyrate, acetoacetate, acetone go away, the bicarb that was being utilized for buffering the acid will be released again, and your bicarbonate will become normal. So bicarbonate supplementation is not required in the treatment of diabetic ketoacidosis at all.
Okay, thank you very much. The final question we have reads, is it always necessary to check for serum albumin level when we have cases of gap metabolic acidosis to correct the anion gap based on serum albumin levels?
So not always. My recommendation would be that those patients who are severely nutritionally depleted, who are malnourished, definitely do it in liver patients because their albumin levels are low to begin with. That is how you can, and again, think of it this way. If you are calculating a gap of 25-30, correcting for the albumin is not going to change the gap to begin with. All you have to do is add another 2.5. That 2.5 is a drop in the in the ocean. Okay. If your gap is coming out to be 10, 11, and you know that 2.5 is going to make or break a gap versus non-gap, then yes, definitely check a serum albumin level. But again, use your resources wisely.
All right. Thank you very much for answering all our questions, Dr. Hasan. Next up, we're going to proceed to the post-CME quiz. My colleague, Dr. Tarek, will be sharing the post-CME quiz link on the chat box, as well as on the dedicated Telegram group that we have created. So make sure to proceed to the post-CME quiz link. We'll be giving around 15 minutes, and then we'll proceed to answering the questions together with Dr. Hasan at the end. Thank you, Dr. Hasan.
Thank you.
Okay, so the first question reads, a 35-year-old patient with AIDS was brought to the emergency room with a fever of 39 degrees Celsius and 3 months history of copious diarrhea. On physical exam, the patient is a well-developed teen in moderate distress. Vital signs, blood pressure is 100/60 in supine position, pulse is 100, and blood pressure is 80/40 in standing position. Pulse is 125, respirations 18, and she was febrile. HNT exam was normal. Cardiac exam demonstrated an S1 and S2 without S3, S4, or murmur. Lungs were clear to auscultation and percussion. The abdomen was supple and minimally tender to palpation, and bowel sounds were hyperactive. Stool was WAC negative, and the extremities were without cyanosis, clubbing, or edema. And neurologic exam was intact, and the chemistry values are displayed here. So according to this, what is the acid-base disorder? So A is respiratory acidosis, B, respiratory alkalosis, C, gap metabolic acidosis, D, non-gap metabolic acidosis, and E, metabolic alkalosis.
Okay, so we'll go through the same stuff that we did. If you can just show the numbers again, please. So again, same stuff that we've done all throughout this presentation. We'll start with the pH, which is 7.35. We'll circle the PCO2, which is 27. We'll circle the sodium, the chloride, and the bicarb. Okay. Now, pH 7.35 is less than 7.4, which means we're dealing with an acidemia. So all the options that are there that are not dealing with an acidemia can be excluded. Number 2, are the lungs trying to help? Yes. The lungs are trying to help because the PCO2 level is less than 40, which is sitting at 27. So that is great. So we are calling this a metabolic acidosis because the lungs are trying to help. Now, since we've labeled this as a metabolic acidosis, the next step is to calculate a gap. Sodium is at 136, chloride is at 112, bicarb is at 14. So the chloride and bicarb total is coming out to 126. 136 minus 126 is 10. So this is turning into a non-gap metabolic acidosis. Now, for the sake of completion, we will do Winter's formula because this is a metabolic acidosis. 1.5 times bicarb, which is 14 plus 8 plus minus 2, will give you around 25 to 29. Patient is at 27. That means this patient does not have an underlying respiratory issue, which means they are adapting or compensating appropriately. Remember, you have to adjust for that plus minus 2 as well. Okay, so whatever answer you get when you do your Winter's formula, add 2 and minus 2 from it. So the PCO2 of 27 is appropriate. So this patient is suffering from a non-gap metabolic acidosis.
Thank you very much. The second question reads, what is the cause of these patients? The patient from question 1, non-gap metabolic acidosis. So urine sodium is 20, urine potassium is 20, and urine chloride is 60. So the first choice reads diarrhea, B is type 1 renal tubular acidosis, C is type 2 RTA, and D is type 4 renal tubular acidosis.
Perfect. So again, now that we've labeled this patient as a non-gap metabolic acidosis, the next step is to calculate what is called a urine anion gap. You take all the positives, subtract all the negatives from it. The positives are urine sodium and potassium that give you a total of 40, and you subtract 60 from it. So you are left with negative 20. Okay. B, C, and D are all options for renal tubular acidosis, all of which will give you a positive urine anion gap. The only option in this question that will give you a negative urine anion gap is diarrhea, as the statement is neg gut active. So diarrhea and plus the patient's clinical history is showing you that they're coming in with diarrhea as well. So the option is A.
Thank you. The third question reads, a 47-year-old woman with late-stage multiple sclerosis is admitted with possible urosepsis. Her temperature is 38.9, pulse is 112, blood pressure is 82/50. Her venous blood gas show oxygen of 42, carbon dioxide of 31, and a pH of 7.33, and the bicarbonate of 18. Furthermore, her chemistry show sodium of 139, potassium of 4.2, a chloride of 102, carbon dioxide 19, blood urea nitrogen 19, creatinine 1.5, and an albumin of 3.6. So what is the acid-base disorder? The first choice is respiratory acidosis, B is respiratory alkalosis, C is gap metabolic acidosis, D is non-gap metabolic acidosis, and E is metabolic alkalosis.
Okay, perfect. Can we have a look at the numbers again, please? Thank you. Okay, so again, everybody, we're going to solve this question just like we've solved every other question. We're going to pick out our 5 numbers from the question itself that are going to be utilized to answer. So first is we're going to circle the pH of 7.33. We're going to pick out the PCO2, which is at 31. We're going to circle the sodium, which is at 139, the chloride at 102, and the bicarb at 18. pH being 7.33 puts us in acidemia, less than 7.4. PCO2 of 31. That tells us that the lungs are trying to help, which means this is a metabolic issue. Okay. Now, because this is a metabolic issue, we are subjected to, or at least have to calculate what is called a gap. And if you calculate a gap in this patient, the sodium of 139, the chloride of 102, and the bicarb of 19 will give us, give me 1 second, I'm just going to quickly calculate it out. 139 minus 102 minus 19. It is 18, 1/8. So we are sitting on a high or a gap metabolic acidosis. Okay. Now, if you calculate winters for this particular patient, you will have to do 1.5 times 1.5 times 18, which is the bicarb in the blood, which gives us 27 plus 8, which gives us 35 plus minus 2. So the range of the PCO2 should be between 33 and 37. And the PCO2 of the patient is at, 33 plus minus 2. So 31 to 37. So the PCO2 is appropriate for this patient. Okay. So the patient is sitting on only a gap metabolic acidosis.
Thank you.
Answer is C.
Okay, thank you. The last question reads, a 61-year-old man with COPD and long-term diabetes mellitus and a diabetic kidney disease is admitted with worsening renal failure, fluid retention, and advancing renal failure. His venous blood gases are PO2 is 39, PCO2 is 39, pH is 7.28, bicarb is 18. The blood chemistry show a glucose of 261, sodium 132, potassium 5.4, chloride 102, carbon dioxide of 18, and an albumin of 2.4. So what is the acid-base disorder? A is respiratory acidosis, B is respiratory alkalosis, C gap metabolic acidosis, D non-gap metabolic acidosis, and E metabolic alkalosis.
Okay, again, we'll start with the same way that we always do. Let's do the simple stuff. Let's do we'll circle the numbers that we have, that the numbers that we have to kind of look at. So if you can show me the numbers again. So again, circle the pH, the PCO2, circle the sodium, the chloride, and the bicarb. Okay. We're going to utilize this for our mathematical calculations again. pH is 7.28, which puts us in a which puts us in an acidemic questionnaire. Okay, so the patient has acidemia. Are the lungs trying to help? PaCO2 is less than 40, which means that the lungs are trying to. They may not have gotten there, but they are trying to. So the PCO2 is less than 40. So respiratory adaptation may or may not be occurring. Okay. The next question is, since this is metabolic because the lungs are trying to help, then we are going to we're going to calculate the gap, which is 132 minus 130. So the gap is coming out at around 12. So this is going to be a non-gap metabolic acidosis because 10 to 12 was considered to be normal. Okay.
Thank you very much. So we've attempted all the quiz together, and we've come at the end of our session. So on behalf of Yetenaweg and everyone that has attended, I would like to extend our heartfelt gratitude for delivering the Common Electrolyte Disorder lecture series in a 3-part. So your expertise and dedication throughout the 3-part series have been truly commendable, and we've received overwhelming positive feedback from our attendees who praised your clarity, depth, and practical relevance to the presentation. So once again, Dr. Hasan, thank you very much for your time and efforts in making this series a success, and we look forward to future collaborations with you.
Definitely. Thank you so much, everybody, for having me. Would love to come back. It's a wonderful experience. Thank you to everybody who was able to attend. Next time, we'll try to be a little more cautious with the time as well. Thank you, everyone. Appreciate you all. Bye.
Thank you very much to everyone that has attended as well. Thank you. We have another webinar session tomorrow from our mentorship team, so you can join then as well. That's it. Thank you and good night.